Dr. Langis Michaud from University of Montreal School of Optometry in Canada. My pleasure to be here at the optometry's meeting in Phoenix, Arizona to talk about the use of contact lenses with dry eye. So we will cover a few things, and the first thing first is to diagnose dry eye patients, symptomatic or not. And the DUCE-3 workshop just established a new guidelines, and it's even easier than ever to conclude that the patient is affected by dry, and then you have to treat the condition, and there are ways to use contact lenses as part of these treatments. Clear lenses, of course, but bandage, contact lens, amniotic membrane, all options are on the table and can be used to help patients not only to see better, but to feel better at the end of the day. So that will be my takeaway from that lecture. So contact lens discomfort at the end of the day is multifactorial, as it was recognized many years ago by the TFOS workshop on this particular issue. But most importantly, it's to reduce the risk factors from the environment, of course, if we can. For example, people allergic to cats are living with two cats, in their apartment. So it's obviously, it just triggers the dryness symptoms. But eliminating the solutions from the contact lens, going to daily disposable contact lens, lid hygiene, of course, and stabilization of the tear film is very important. And at a given point, some materials are better than others, just to reduce the friction and to keep water where it's supposed to be. Water gradient, for example, is one new technology that is available and made a difference for many patients. Adjunct use of medication like cyclosporine to stabilize the tear film is also something that we are using on a regular basis and helps a little bit, certainly patients to wear their contact lens more comfortably. In fact, there's just one good tip that I can give to a practitioner is during your refraction, before even considering contact lenses, if the patient blinks to make the letters clearer and to give the appropriate answer or which one is better, one or two, then that means that this patient is affected by marginal or advanced dry eye. If the answer during refraction again is fluctuant and certainly going everywhere, that's another sign. And obviously your slit lamp exam will confirm this. But just looking at what patients describe as symptoms and how fluctuant the vision is will tell you that tear film is affected and certainly has to be treated before anything else. There's not a single innovation. Manufacturers did a tremendous job, all of them, to provide practitioners and patients with state-of-the-art materials nowadays, solutions as well, but materials are better than ever. I think that one of the key elements that we are missing over the last 20 years is the fact that we don't fit the lens anymore. We just throw the lens on the surface because we don't have an option of base, curve, and diameters, and we hope for the best. Recent studies prove that the sagittal depth of the lens should be around 200-300 microns over the ocular sagittal height. And this is the best relationship from a contact lens to the ocular surface. And we don't pay attention to those details. So I think that in order to improve over the material and solutions, to revisit the way we are fitting lenses, to have the appropriate diameter, a lens that is moving, favoring tear exchange, will provide the next step and the best options for the patient to be more comfortable with their lenses. It's a case-by-case approach. In fact, in my practice, I consider every contact lens patient as a potential dry eye patient, and I treat aggressively any kind of lid disease I can identify, and certainly I try to stabilize the tear film as much as I can in order to provide them many long years of successful contact lens wear.